Good afternoon, everyone. My name is Meg Snook, and I am the Administrative Assistant with the Regional Palliative Care Leadership Team located here at the Dr. L.A. Miller Center in St. John's. I'd like to welcome you to our Palliative Care Grand Rounds webinar. Today's topic is fundamentals of providing end-of-life care. This topic will be facilitated by Carmel Collins, our nurse practitioner, and Dr. Susan McDonald with the Palliative Care Pain and Symptom Management Service here at the Miller Center. Time permitting, Carmel and Dr. McDonald will answer questions at the end of the presentation. But if we do run out of time for some reason, you can email it to me, margaret.snook@easternhealth.ca, and I can forward your questions to Dr. McDonald and or Carmel. To ask a question, I ask that you raise your hand at the end, and I will unmute you. Writing in the box, I just don't have so many people on, I probably won't get to you. So if you raise your hand, I can see it right away. So now I'm going to take a few minutes, and I'm just going to change presenters. All right.
We have a
technical... Carmel, I changed over presenters now.
Okay, thanks, Meg.
You're welcome.
All right, just a second, everyone. We'll be right with you. I have a temperamental computer here, so my apologies for the delay. This is Carmel Collins. I am, as Mag said, the nurse practitioner with the palliative care team here, based out of the Miller Center, but obviously providing palliative care services for all of Eastern Health. And most of my role is clinical, although I do enjoy having opportunities to talk to people and to provide some education around something that I've spent most of the last 35 years of my career working at. And sitting beside me is my colleague, Dr. Susan McDonald. Susan, you can introduce yourself.
I'm a palliative care physician with the service and have been for the last 20-odd years. More than happy to provide whatever information I can for the listening audience today.
So as the title says, we're going to talk about the fundamentals of providing end-of-life care. And this was one of the topics that we got some suggestion about when we were kind of polling our audience as to what they would like to have us talk more about. Susan and I typically like to do a really interactive presentation, but understanding that the scope of the technology right now, that interaction is going to be held till the end. So please, we invite you, if you have a question, jot it down. We are happy to provide any information we can that we don't cover. We'll kind of talk back and forth and share the presentation because we do talk together a lot, and that's just kind of our style.
Yeah, I think looking at this objective, probably the most important word in it is holistic. Oftentimes we get caught up in our particular field of practice, and we are looking specifically at the thing that we have been trained to look at. But in palliative care, it's incredibly important to think about the entire person, and not only the person, but where do they fit within the family, within their community, and the larger picture. So the holistic aspect is really important.
And the next slide and the following slide, actually, there's questions on them. And these are things that we want you to kind of reflect on right now as to what do these things mean to you. So what is palliative care? What are your thoughts on that? Why is it important to talk about, to learn about, to practice palliative care? And then who is it who actually has a responsibility to practice palliative care? Does this involve me? And when is a palliative care approach appropriate? So I just give you a little bit of a lead in on that one. A palliative care approach is palliative care provided by people who are generally not specialized in a practice that's 24/7 palliative care. And then when you think about all those things about palliative care, we also want you to think about, is palliative care the same as end-of-life care?
Because I think a lot of people believe it is. And certainly, if you look at the history of where did palliative care come from, it came out of the dissatisfaction that, particularly here in Canada, that several oncologists were having in regards to cancer patients and how the transition from very active, aggressive care to very end-of-life care and dying was quite abrupt, and patients didn't have a chance to have good symptom management. And so our founders of palliative care here in this country really worked to make that final stage of somebody's life as good as possible from a symptom management perspective. But palliative care, as many of us know, has changed over the last 20 years, particularly, I guess, in the last 10, and it embraces much more than just end-of-life care now.
And you may think to yourself, well, gosh, I came onto this to talk more about end-of-life care and how to manage that, but I think it's important, as in any aspect of a topic, is to understand the foundations that it's built on. So just put up here the definition of that Eastern Health has embraced for what is palliative care. And it's a lot of words, I apologize, but I wanted to include it in its completeness. I've bolded a few lines there. Relieving suffering, improving quality of life, end of dying. It's the different domains of physical, social, psychosocial, spiritual, and the practical issues that patients and families encounter. You want to address their needs, their hopes, and their fears. Looking at individuals and how they are coping with loss and with grief during the illness and bereavement. And for some people, that's a kind of a shock that we would put during the illness there. But we're going to talk about that in the coming slides, how the losses that people occur while the patient is alive, the losses for the patient for the future, the losses for the family for the future, and then certainly after the death of someone. That's something that needs to be addressed. And then palliative care is appropriate for any patient and family living with a life-limiting condition at any point in time that they're experiencing symptom difficulty, as long as they're willing to accept that focus of care. And it's a big component of it is provided by patients, caregivers who are professionals, but also volunteers and family members. So it's a very broad scope that we capture when we talk about what is palliative care. I put up this little cartoon that I developed because I think it captures what Susan is saying. It's palliative care subsumes end-of-life care, and oftentimes we think of end-of-life care being in that little bracket that we say PC or the palliative care unit, because many people think palliative care is a place to be, but rather it's a way to live life well for the entirety of one's life until the natural end of life, which is death. So there's lots of pain and symptom management that happens at any point under the umbrella of a life-limiting condition or a chronic disease that someone will live with for the entirety of their lifespan. There's also the grief and bereavement that happens while that process is happening to the individual and thereafter. And this is just part of comprehensive health care, which is where the role of a palliative approach to care comes in, because you don't have palliative care specialists at all points in the healthcare system, but you certainly do have healthcare providers who are trying to meet the individual needs of patients and families at all points in their life. And so to make someone feel comfortable and to live well, that's part of comprehensive quality health care. Bottom line is, the word palliative simply means to make people feel comfortable, to do something to improve the quality of one's life through comfort.
One of the things we often hear from people is, well, if you'd only just change the term, if you just stop calling it palliative care, people would be comfortable with it, because there's some negative connotations that come with palliative care. Well, they have looked at doing that in other places and did try different euphemisms or calling it St. John's House or whatever term took their fancy. But very, very quickly, people come to understand what that new term means, what the old term does. And more, it's a reflection of our overall societal discomfort with thinking about and facing end-of-life issues and what that means. Because let's face it, this is sad stuff. It is hard to look after a patient or a family member who has a finite time to live, And yes, the focus can be on trying to make that as good as possible through particularly pain and symptom management, but other supportive things. But it's overall, it's sad, and you just can't get around that.
And when we try to approach situations, obviously we're practicing individualized patient care, but we kind of group our practice, I know I do in my clinics and in my home visits, into two basic areas. First, I want to address how you're doing in the here and now. I think that's really, really important. Whether the here and now is you've recently been diagnosed and you're up around doing things functionally, you're able to achieve most of your activities of daily living. You may not be able to do your job at work. You may be off on sick leave, but you're functionally up and around doing things. Or if you're more towards end of life and you're confined to bed because you're quite fatigued. I address the here and now in terms of what pain or other symptoms might you be experiencing. I want to focus on why are you experiencing those things. So it's important to know for me as a clinician and from other healthcare providers, know what's going on with the illness that the person's experiencing. What do I think that impacts on them physically, in what way? And then I need to establish with patients, what is their goal of care? What do they need to have their day improved? What is their goal for comfort? And then there's there's a snowplow outside the window. Variable frequency of interactions, it depends on what the patient needs. Some patients have a high burden of symptoms and we actually see them several times a week, probably phone another couple of times a week. Other patients meet us and their symptoms are managed fairly easily and they actually have their care provided by a non-specialist clinician. So they're going back to their family physicians, their nurse practitioners in the community, their community health nurses, their spiritual care providers, volunteers in the community, Meals on Wheels, things like that. And then the model of patient and family support to live with transitions throughout the illness trajectory, I think is really important, which means that you're there to support people at the times in their life when they feel vulnerable. Symptoms may be burdensome, or maybe some other aspect of how their life changes is burdensome to them, which leads into the next slide, which means we talk a lot about future care planning and engaging in conversations that sometimes people will say, I don't know how you do that because that's tough stuff to talk about, which Susan has mentioned. And yes, it is. But it's meeting the patient where they are, talking about things that are important to them at the time that they feel they want to talk about it, or at least bringing it up so they're aware that someone's interested in talking to them about it.
I think advanced care planning is incredibly important. And if we look under the guise of using patient autonomy, and that this improves patient autonomy, then sometimes there can be less of a sting to the conversation. When I talk to patients, I'm really emphasizing that this is your opportunity to keep things as much under your control as possible. You didn't choose to have the sickness. You didn't choose to have the sickness worsen. You didn't choose to have the surgery not work, et cetera, et cetera. But there are some things that you can still choose. And let's get those out there and documented so that we all know. So if there comes a point in time when you can't tell me any longer, then I have the peace of mind of knowing that I'm doing exactly what you want. I also talk about that this is a tremendous gift for families. Most families really struggle when their loved one becomes too ill to let them know what they want. And they struggle with, am I making the right decision for my loved one? And then they struggle living with the decisions that they made. Was this right? This is what he wanted? How would I know? We never had that conversation. So we talk about it in the guise of, this is a legacy that you leave your family. This is one of the last things you do to take care of the people that you love. And that's a real positive thing. Oftentimes reframing it in that way does help people understand and allow them to participate in this kind of conversation. But really, here's a little plug. All of us should be talking about advanced care planning with our family members. And I would say perhaps at Easter dinner, everybody here who's online should be thinking about having a little conversation over Easter dinner about making sure that you know what you can do for your loved ones should they not be able to speak for themselves. Get some basic ideas of what they would like and probably more importantly, what they don't want.
And I think when you look at this too, you may be sitting there thinking, well, wow, I have many encounters with patients who are living with illnesses from which they will likely die. This is a lot for me as an individual to do. How do I know where to start? How am I going to do this? Well, first and foremost, your patient is your guide. When you get that opportunity in a conversation, feeling comfortable to kind of push through, even if it's not exactly your comfort zone, to ask the patient, tell me more about that. You just mentioned something that makes me wonder why you brought that up today. What does it mean to you when you tell me this? Be prepared to listen to the answer, because that's what's going to guide you. Know that you're not alone. Some people may say, easy for myself and Susan to say that. We're in St. John's with a big team of people around us. We've got all kinds of social workers available to help us out, because social work has such a huge role in counseling support for our patients and their families, grief and bereavement services, spiritual care individuals. But even if you live in one of the smaller communities in this province, you'd be amazed at the network of clinicians who are there to help or guide you. If they can't do it in person, can they be a resource for you remotely? Can they interact with your patients remotely? Is there an opportunity there that we don't tap into? With this age of FaceTime and Skype and things like that, can we use those kinds of technology to connect people who are at a distance to provide that level of support that patients may need, or you as a caregiver to have? So think outside the box when we think about future care planning.
Yeah. And nurse practitioners and any family physicians who are on this webinar, please remember the e-consult program allows you to connect directly with somebody here in palliative care and get your answers to your questions about a specific patient, which you then are able to include as part of the patient's chart. And that can be very helpful.
The next slide actually addresses what barriers have been identified to providing palliative care. And why this is here is because sometimes we talk about it, we hear about it, we talk to colleagues about our frustrations, but you wonder if you're in isolation. You wonder if other people have this struggle. And so in the literature, it does show that there are reasons why. And one of them is that we're uncomfortable as healthcare providers sometimes with these discussions. The unpredictable nature of illness. Think about chronic diseases like congestive heart failure. Patients are better, they're more well, then they suddenly get really sick, then they rebound, but maybe not to where they were before they got that last episode. But you're wondering, should I talk to them about, oh my gosh, things are changing, when actually then they rebound and they're pretty good again? I often find, and Susan as well, we use the surprise question. Would I be surprised if this patient died in the next 6 months? You can actually extrapolate that out to a year, really. For some people who are a little more uncertain, I find if you think, 6 months, you feel a little more secure in the conversations about advanced care planning. But really, any acute event could happen to someone who you wouldn't be surprised might die within the next year. The other piece, and it's supported in the evidence, is lack of knowledge, lack of formal education, lack of continuing education being provided about palliative care. As Susan started to talk about, historically we've been seen as hospice or end of life, so people don't think it's appropriate to talk sooner than later. It's appropriate to talk when the patient has symptoms and needs assistance. So how do we enhance that? Well, that's part of our job here as specialists in palliative care, to be, as Susan said, a resource through the e-consult. Pick up the phone and call us if that doesn't work for you, if we're actually seeing same patient. Know that you're supported, and while we may not be able to make on-the-ground changes for you, we can help guide, is your decision-making on the right path, if you just want some feedback. And so realizing that we're here to support you. And I think that addresses a lack of communication. If people don't know you're here, how can you feel supported? So we want you guys to know the services, it does exist. And while we have a regional mandate, we certainly don't turn people away if they call from Labrador to talk with us.
Absolutely not.
We're delighted to hear. Why are people afraid or don't talk about palliative care? The bottom line in research says, of all those things on the previous slide, many people are afraid of taking patients' hope away. They feel like, how do you talk about this tough stuff to someone? Things are changing. It seems obvious to the care provider that we're moving more towards an end-of-life phase. And yet, how do you talk to someone about this tough stuff? Because it's sad, it's emotional. You reframe hope, as Susan mentioned. you look at what opportunities can you provide by having the conversations themselves. And this is part of end-of-life care and symptom management. That's why we're talking about it so much. It's the critical aspect of getting to provide patients the insight that you have medically to afford them the opportunity to prioritize what they want to do. They may reframe totally their goals of care, reprioritize them if they understand where they are in terms of the context of their living. Now, can we predict with accuracy? We're pretty lousy guessers at that.
Absolutely.
I think what we can do is provide a guide in terms of if somebody says, do you think I still have 5 or more years left to live? And you're thinking, yeah, no, I don't think we're talking years. You can actually say, you know, I understand that you're asking that question because you want to get an estimate. And while I can't be totally accurate in predicting time, really nobody can, I can tell you that I certainly don't think that we're talking in terms of years. Maybe, you know, months to many months, if that's what's appropriate for your individual in front of you that you're treating. Many times in our practice, as we watch people transition, we do have to say, you know, we look at the rate of decline in their ability to do things over the past several weeks to a couple of months, and based on how rapid that change in function has been, the conversation may be more in terms of, you know, I'm actually seeing such a rapid change that you're recounting to me. You say to the family, you know, I actually think that we're moving in the direction of maybe days to weeks. They haven't exactly given a direct pinpoint timeline, but you've certainly helped reframe the context of what people are looking forward to as in future time.
I find it very helpful when patients are asking about this kinds of things to ask the question, what are you hoping for? And people range in their answers from from things that are incredibly unrealistic. I'm hoping I'll be miraculously cured, to things that may be more within their grasp. Things like, I'm hoping to see my first grandchild born, baby's due in 3 months. Or I'm hoping that I'll be able to get to my daughter's graduation from high school. That happens in 2 weeks. And when you have something concrete that the patient is hoping for, then you can create a plan of care that includes some things that are quite realistic. And if you don't think that the patient is going to live long enough to see the grandbaby born, then you might look outside the box and think to yourself, how can I be really creative in this situation? It's not all about prescribing the pills. Sometimes it's arranging an ultrasound so that you can get a fetal scan so that the loved one is able to see the unborn child. Those kinds of things are incredibly important. They foster hope. They don't take hope away. And we can't change the fact that something terrible is going to happen to that patient as much as we might want to. And we have to be as realistic as possible. But I agree that reframing, what are you hoping for, can be very, very helpful.
And right now, to this point, you're probably thinking, I thought they were going to talk about, you know, nausea, vomiting, constipation, and all that stuff.
Oh, we
will, guaranteed. But I think if we were not to spend as much time as we have on this critical step, then treating symptoms in isolation of what the patient's experiencing on different levels is not of benefit. This is a very important part of what we weave through the practice of palliative care. So we often talk about the art and science of providing care. This is the art of what we do, and we weave the science of symptom management through it. So I think that if there's a take-home message today, this is as critically important as managing somebody's pain and other symptoms. It's interesting when people are afraid that they may take people's hope away, because another study shows, 2 other studies actually that I put up here, address what do patients and families want. And the stuff that we're afraid to talk about is actually what they want. They want symptom control. They want attention to their personalized care needs. How do I cope with the change in my life? They want to prepare for end of life. They have things that they need to do and get in order. Not everybody has a will. Susan talked about your substitute decision maker. Having measures in place while you're well, generally healthy, clear in your thinking, and able to make plans for the future is a good thing to do. Being able to say goodbye or completing tasks that they've left undone, whatever they may be. And, you know, looking at in terms of conserving dignity, what would in my plan of care make me feel like totally respected as the individual I am in the context of who I believe I am as a person. And having the trusting, caring relationship with the people who are going to look after you. Many times with end-of-life care, what I find is people are not so much worried about the actual dying It's who's going to look after me and my family between now and when I actually die? And who's going to look after my family after I die? Who's going to make sure that they're doing okay emotionally, spiritually, financially? All of those things that if we don't talk about what's going on, how can people address it? So we'll move into the more concrete physical symptoms. So why treat pain? Well, that seems quite obvious, but you'd be surprised. Sometimes we kind of move through things and we try to treat the physical pain, like Susan said, with the medication or whatever, but we need to think about why we're doing it and how we're going to address things. So, you know, there have been studies out there that say treating pain as a symptom improves the quality of living at all stages of life, which includes end of life, by the way, and it can possibly increase the length of life, which is important, because if you're living with a life-limiting condition and your symptoms are better controlled, not only do you live better, but you may live longer, which is kind of a nice thing. We're all about promoting quality of life, but not prolonging suffering. The total pain experience is a concept that many of you have heard about, but I think is important to reiterate right now. And as Susan had talked about earlier, and I did as well, it's important to tap into how is the patient feeling on many levels. The definition that I put up addresses this as well. I find that if I have a symptom in terms of pain control that's challenging to manage, and I just can't seem to, as diligent as the patient and I are working together with the family, making sure that we follow the plan of care to see, can we improve the symptom? Sometimes the symptom's persistent. And what I find is at that point, I need to go back and kind of reset and look at the domains of total pain. So the spiritual, the emotional, physical, sure, the psychological, and say, what have I missed? Is there something that I haven't talked to my patient about that maybe is a key to why this is challenging to manage at this point in time? This is where assessment is important on part of the prescriber, but also the other input from other team members, because it may be the nurse who's on at 3 a.m. who actually finds out the key to what the problem is, because the patient is talking to her or him and says, you know, I've got a lot going on in my life that I haven't talked to anybody about. I've got a daughter who has an addiction issue. She lives away. I'm really afraid of taking these pain pills when I'm at home. I'm afraid to have them in the house. And there can be all these different layers that if we're just writing a prescription and walking away, we don't get to know and we don't understand. So it's a multi-faceted approach to the care of an individual that involves many different people on the team, and the communication, once again, is very important between patient, family, and care provider, but amongst care providers as well.
I think one of the keys in looking after patients with pain is really taking your time and doing a thorough assessment. We often prescribe or move to prescribe too fast, prescribe too quickly, and then we don't give a really good chance for medications to work. And we jump from drug to drug to drug after a couple of days, or not a thorough or appropriate trial of medication. So when we're looking at our patients with pain, it really behooves, it's in all of our best interests to really take the time, do a thorough assessment, find out what the issues are, and then following the WHO ladder, start with the weakest drug you can get away with, give a really good trial of that medication before you throw in the towel and move to something else.
We've had some other presentations as well in this webinar series that we've been doing. Dr. Hurley talked about pain management, I believe, and we, in different presentations that I've done as well, brought up, you know, assessment tools and using those as clinicians to guide our practice. So most people, particularly community health nurses, are familiar with the ESAS scores, the quantifying of what a symptom feels like to an individual based on a scale, a numerical scale from 0 to 10. Using a tool like that consistently helps us decide how much impact we're making on the quality of that person's life based on their subjective perception of how it feels to them, and they quantify it with a number. So hopefully if I treat someone for pain and we're successful and we look at the total person pain picture, we move from somebody having a pain score of maybe 8 out of 10, which is pretty severe, to down to maybe 4 out of 10, while still classified as moderately uncomfortable. Is a heck's a lot better than 8 out of 10. And patients will generally say, if you can get my pain down from an 8 to a 4, I'm so happy with that. using the PPS score, which is the Palliative Performance Scale, to determine functional status and to look at that over time as to how well is my patient doing. Tools like that are really, really important to help in manage a person's symptoms, including pain. I think the other thing when we talk about pain, it says in the last bullet, opioids are not the only treatment. I agree with Susan. Looking at the World Health Organization analgesic ladder with its 3 steps on it is really important. Tylenol can be beneficial to patients. It doesn't have to be morphine or Dilaudid. People are taking Percocet or Tramadol. It's what's right for that patient at this point in their life. Some patients with cancer, for example, never have pain. About 20% of the population don't experience pain. So if people are sitting waiting for pain, wondering when it's going to happen, you can assure them that not everybody gets pain. Sometimes pain is misrepresented. Patients say, I'm not having any pain, I'm doing well, and families sitting around shaking their heads. As the patient calls that discomfort. And unless they were actually writhing in pain, they wouldn't call it pain. So once again, how the pain scale is important, the 0 to 10, to kind of see what the patient thinks is his discomfort level and to improve on that. I think the other thing is as well is we use other medications. So not to get into doses and specific drugs, but aside from the opioids, you may see some patients are taking for nerve pain, for example, they may be taking a tricyclic antidepressant, a drug called Elavil, for example, or amitriptyline. That helps the misfiring of the nerve for people who are having numbness and tingling that's persistent in an area, or maybe a lantanating shooting pain. Other people take steroids to help with pain because they're a powerful anti-inflammatory. But all these drugs have side effects, and so education around and knowledge of you as a care provider about what the side effects are really important in supporting the management of someone's pain.
And it's not just drugs.
That's right.
Pain can be we can assist people's pain by looking at non-pharmacological things like, for one, is there any physio? Is there any equipment that can make their life different? Could applications of heat or ice or massage or acupuncture, any of those kinds of things may be beneficial to a patient and are worth exploring. It's important to recognize that the only treatment is not just medicines. That being said, opioids are the basic medicine that's required in patients with pain, particularly end-stage answer pain. And it's very important that people recognize and respect these medications as an important part of the armamentum that you have for your patients. You shouldn't be frightened of using these drugs. You should be respectful.
You may be thinking to yourself right now, okay, so while patients up and around and able to tell me they're in pain, I feel comfortable giving them their pain medication as it's ordered, or if you're a nurse practitioner or a physician, ordering the pain medication, prescribing it. But what about when a patient's like near the end of life and they're not as responsive? In fact, they may have minimal opportunity to be responsive. Life's winding down. Should I still be given pain medication? Do they need it? How do I know? Families are questioning. Do they really need pain medication? My loved one hasn't told me anything. Well, this is where clinical assessment comes in. I guess our basic tenet is if somebody's being treated for pain, prior to having a semi-conscious or an unconscious state, we work with the presumption that the pain didn't magically disappear, but rather that it's persistent. And that it's actually the medication that's keeping it under control. And so while we may adjust doses over time based on the patient's needs, we work with the tenet that likely the pain is going to be still there. We don't want to stop pain medication and throw somebody into a terrible pain crisis. So looking at the patient in front of us, assessing how they look. Sometimes patients will grimace in their unconscious state. If they're turned in position, they may moan, using medications to minimize that experience. So if someone's on regular pain medicine every 4 hours, say by subcutaneous injection, and they have a breakthrough dose, then if the patient consistently has this problem that every time you go to reposition them or to help with their personal care, they grimace or they moan, perhaps giving them breakthrough prior to that activity, maybe 15, 20 minutes prior to planned activity like personal care, so that the individual's experience of pain from that episode is minimized. We can't always prevent it. We never promise pain-free, but we can certainly help to minimize the pain experience. Anything you'd like to add there, Dr. McDonald?
No.
Okay. So we're going to move on to some other common symptoms. You'll see those here, and we have some more on the next slide as well. These symptoms can be experienced basically at any point in life, and the ones we address beyond that will be more towards end of life, but we'll chat about these first.
So constipation is the bane of our existence, and it's probably, many of you are very much involved with patients who have pain and take pain medications, you'll recognize that constipation is our constant enemy. I think one of the things I'm always harping on is that people need to be vigilant, and that constipation isn't the lack of stool necessarily, it's the straining at stooling. And so oftentimes we focus only on, did you have a bowel movement? When was the last one? And then we tick that off our list saying, yep, okay, they're good. When in fact, the patient was back and forth to the bathroom several times. They sat there, they strained for ages. They were really uncomfortable before they managed to pass a small stool. So where constipation is concerned, this is where the adage, an ounce of prevention is worth a pound of cure really is absolutely true. Anybody who is taking pain medication should have a regular laxative order. That doesn't necessarily mean that they have to take a laxative every day, because people are different. What works for one person may not necessarily work for somebody else. But they always have to have a laxative available. And probably more crucially, they need consistent education and support in regards to when do I employ the laxative and when can I hold off. Many times we see patients who have a laxative order, they've got the Senokot at home, they've got a little bit of lactulose, and they have the glycerin suppository. And you say to them, when did you last stool, and was it easy? And they say, no, I've been straining, and straining has been awful. And you say, why didn't you use your Sena? And they said, I don't know, I forgot, I didn't know I was supposed to. Or I was waiting for the nurse to tell me. So listen, we have to educate and empower our patients to look after their bowels well. And I call this the peanut butter and jelly theory of palliative care, that anytime you write a prescription for an opioid, there must be, that's the peanut butter, there must be the jelly. And I'm not talking about Colace, which is a useless drug, so don't even be handing that out. But I'm talking about the peanut butter and jelly. Means that the opioid goes with the laxative. They go hand in hand, side by side, and not one without the other.
So you may ask, what if my patient is actively dying and their bowels haven't moved for a day or so? Well, if it's a day or so and the patient is obviously at the very end of their life, we tend to not be running in with enemas and suppositories and trying to get their bowels to move. But if someone's life is gently winding down and you think things are changing, they haven't been eating as much, but it has been 4 days since their bowels moved and they're still eating, and they're still able to sit up and have a conversation with someone, while life may be winding down, I would still then focus on how can I help make them feel better, and attention to the bowels are important in that circumstance as well. If you don't help with the bowels, sometimes you get the next problem, which is nausea and vomiting.
Yeah. I just mentioned a little bit about constipation in the unconscious patient. So we do see patients who are with a PPS of maybe 20% or 10%, and they've been in that state for quite some time. And we get concerned about bowel function, even though the patient is not taking any liquid or solid food at that point. Why? Well, you're not just cleaning out excess food or used up food, but you're cleaning out the sloughed off cells from the intestines that are constantly renewing itself, and all the bacteria in there. And we do know that if people have bacterial overgrowth for too long, that can cause all sorts of problems, including agitation and delirium. And even though the patient is in an unconscious state, an agitated delirium does not make the dying process easier. So if you do have a patient who is actively dying, you might not be quite as vigilant with looking at daily or every other day stooling, but you certainly aren't going to leave it for 4, 5, 6 days at a time.
No. And this is where the assessment tool comes in handy. So the PPS score, that snapshot in time on how was my patient a week ago? Were they up walking around, out shopping? And suddenly things started to dramatically change. And now we're at an end-of-life situation where it seems almost hourly the patient's status is changing and they're getting more towards end of life versus this more subtle transition, which can happen with some patients. I would say more often with non-cancer patients than it seems to happen with the patients I see with oncology, but rather a more progressive decline or patients who are in a persistent vegetative state. For those of you who might work in an intensive care unit, people who are, sedated because they need to be for various reasons, you would monitor their bowel function and certainly try to manage it better. Patients in long-term care who may be bedbound for long periods of time with minimal responsiveness. So yes, those patients certainly would be treated differently in terms of their bowel function. So constipation's first, because as Susan already alluded to, you can get agitation and restlessness, which we'll talk on the next slide in the context of end of life, but you can get a delirium or restlessness related to constipation. You can certainly get nausea and vomiting. We often use the analogy of if at home your kitchen sink, the pipes got blocked up, then things back up into the sink. Think of your bowel and the stomach. If the bowel gets blocked off, it's not functioning well, things start to pile up and back up into the stomach, creating nausea and vomiting, and that's a terrible situation for patients and for their families. So managing nausea and vomiting is something that we are quite in tune with. If the patient is more well and they're swallowing fluids okay and their bowel is functioning fine, we may use something like a prokinetic agent, something like Metonia or Maxaran, an oral medication. But if the patient is vomiting and can't keep things down, then you need to look at an alternate route, because no sense taking pills by mouth if you're going to throw them up again 10 minutes later. They're probably not going to help you out much when they're in the bucket. So using subcutaneous route is our preference for individuals who have persistent nausea with vomiting. And it can be the same medications, but I think critical to that is assessing the bowel status, because if someone is having a bowel obstruction because they're so constipated or because there's tumor blocking off their bowel, you don't want to give them medications that are going to force the contraction of the bowel to try to move the stool through, and use that as a mechanism to treat their nausea, because you could actually run into great difficulties with perforation and peritonitis. So we don't want to do that. Like that there? No. Anorexia and cachexia syndrome.
Oh, yes. So everybody knows that as life winds down, our bodies change, but I think it's really important to remember that there's some physiological changes that sometimes we're not as in tune with. And the physiological changes that happen with end-stage cancer, end-stage cardiac disease, end-stage liver disease, for example, all could fit into the term anorexia cachexia syndrome. And this is basically a state of abnormal starvation, where the body, some mechanism gets turned on in the body, and the metabolism increases, the muscle mass starts to decrease because the body's using up the muscles and catabolizing it. But at the same time, the ability of the body to take in and use nutrients from food and drink becomes impaired. So you have a person who is losing weight, sometimes will be having a very slight fever, seems to be getting smaller, and you think to yourself, well, if we could just feed them enough, all this would reverse. But in fact, they start to run into trouble with their appetite, change in taste, feeling full very quickly, and eventually many people lose their appetite altogether and are not interested in eating. Some people think that the treatment of this would be to start parenteral nutrition in some form, either by tube feeds or intravenous, but in fact the science demonstrates that this only impairs things even worse, and that the only treatment, once a patient has fallen into this condition, is to allow them to eat and drink what their body asks for, the amount it asks for, and when it asks for it. I've found over the years that this is one of those things that people respond generally very well when they understand that this is a physiological mechanism, when they understand how their body is changing and why, that there isn't a magic pill to fix it, and that they will not starve to death because of this condition, but in fact that the body knows what it's doing, it's winding down, and the best that they can do is to follow their body's instructions and eat and drink what they want. So usually when this has happened in end stage, I tell patients, anything you like to eat, you can have as much of it or as little as you want. There's no guilt involved whatsoever. Where the real challenge is in how families manage, because families really struggle watching their loved one dwindle away and eat less and less and less. And it's, I think, it's probably one of the most difficult things for a family member to watch and feel absolutely helpless. So we help families understand, again, the physiology, but also how can they divert their energy for caring for their loved one into something that's more productive or more helpful, rather than the food, which the patient can't take and in fact can become unhelpful. How can we find them? How can we help them find other ways of showing that they love their loved one, that they love them? And so sometimes things like massage or that kind of thing can be really helpful in diverting the family's healing energy to something more productive.
And I agree. In my experience, the patient is often relieved that someone identifies this and can rationalize it for them. And families, while they're still concerned, at least they understand the process, and that's really important. These symptoms are grouped together because we see these a lot near end of life. Skin color changes or mottling, that purpley blue color that patients get sometimes around their heels and their ankles and their toes, their fingertips, around their knees. That's normal. And I think the thing is normalizing all of these things in most patients' families. In this day and age, many of them have not experienced someone dying. We tend to take it from the home and move it to a hospital situation. So providing not only comfort for the patients, but comfort in terms of emotional support for families and normalizing the process as life winds down. So the skin color changes that can happen, it's literally the peripheral circulation starting to shut down. You can get changes in temperature of the skin because of that, so the skin can be cool. I have noticed many patients a couple of days before they die tend to spike a temperature. I think that's the deregulation, that's the hypoxia that people experience as life is winding down, and normalizing that for families and saying, you know what, sometimes temperature does spike, sometimes the skin does get cold. These are all normal processes, and certainly what we do is supportive care in terms of the education and comfort measures. So if somebody has a temperature, acetaminophen, probably rectally by suppository if the patient can't swallow. Changes in breathing pattern. Patients' breathing gets deregulated, once again, probably related to the hypoxia that someone may have. We put oxygen on if they're short of breath, but we're not doing any investigations in terms of blood gases and things like that. We're basing our care on the presentation of the individual in front of us, looking at how we've managed to date and how we can continue to manage with comfort as being our focus. So normalizing this for families and saying, you know, breathing can get rapid and very shallow, or it can be very deep with long pauses called apnea, that this is normal. It will vary between the two. Sometimes it will go back to normal for quite a long period of time. Sometimes the apnea may seem like forever, the pauses, but it may only be 15 seconds. But when you're sitting next to your loved one's bedside, that can seem like a lifetime. Providing support so that people aren't timing the pauses and they're focusing more on the person than their iPhone and the timer on it. So that's really important. Talking about what could happen to a patient with their family, expressing to them that if they have difficulty swallowing, even the spit at the back of their throat can pool. The stuff we normally swallow with ease and never notice thousands of times a day, that becomes more difficult. And so it's noisy and wet, and that there's medications we can use, but it only works in about 50% of us. So if we use some scopolamine, a medication we give by needle to help dry up the secretions, it may or may not work for the person in front of us, the patient experiencing the symptoms, but providing a sense of comfort to the family that it's not distressing to the patient. One of our colleagues here often referred to it as, if you're the person sleeping next to a snorer, the snorer is not bothered at all, but you sure are. It's a similar situation.
All right. The other things that are quite common in the end of life are things like changes in cognition and agitation and restlessness. So delirium, agitation, and restlessness. So delirium is a change of cognition and a change of consciousness. So you get people who may appear to be excessively awake and very active, and they don't, they've lost touch with who they are perhaps, or what's going on, can't keep things straight. And then you also see a hypoactive delirium where people are sort of lying in the bed and they may be a little bit sleepier than usual and they're not causing anybody any trouble. Anytime you see a change in cognition, you should be really thoughtful, because it may signal that things are changing, that the end is near, because it is a very common experience before an end of life. But also it can happen much earlier in the trajectory of the patient's illness and their living. And when that happens, it can mean that there is some sudden change somewhere that needs to be checked out. If you do not address the delirium, patients can die because of the delirium. Agitation and restlessness are, again, very common at very end of life. We see this from probably up to 90% of the patients here on the palliative care unit. And it's really a result of, as the body changes and things wind down, there's lots of neural changes in the brain that are occurring, and dysregulation of normal processes, and things get a little bit off balance. So it's very common. We usually use small doses of sedatives, sometimes a little bit of haloperidol, sometimes a little bit of methotrimeprazine or Nozanan, and our fallback is usually something like midazolam, which is a fast-acting medication given subcutaneously, and usually out of the system relatively quickly, although for some patients it lasts quite a long time. The purpose of that point in time is patients may not be aware that they're restless, but their family certainly are. And so we're treating the patient's restlessness in order to have the patient more relaxed and calm, and not distressed, and also to have the family relaxed and calm and not distressed.
And I guess when you listen to what we're saying, I mean, we treat all these symptoms, but we keep coming back to the support of the patient and the family, the understanding of the process of what's going on, the normalizing the changes at end of life that are anticipated, but people may not be aware of. And we're going to show you some resources at the end of the presentation coming up. I guess, you know, when we look at things, we're doing things to provide comfort. So when we have the wet, noisy breathing, we're using medication to try to dry up those secretions. We're not sticking a suction catheter down to the back of someone's throat where it's too deep to reach, causing them to be restless and agitated, and then having to medicate them for that symptom. We're looking at how do we approach things in the gentlest way possible. I guess in essence what we're saying is this is looking at the person in front of us, addressing the issues of concern to them, supporting their families, and providing good basic nursing care. And I use nursing in quotations, I use basic in quotations. I'm a nurse by background, so certainly I identify with that, but that is the care provided by anyone looking after the personal care needs of this person. And you know, it's the things that we haven't talked about here, but what we couch as nursing care is, you know, mouth care. Making sure that the lips are not dry and they have some protection on them, making sure someone's turned and positioned. I'm from a nursing age where back rubs were done. Susan is as well. She was a nurse before she was a physician. Rubbing someone's feet, putting on quiet music that the person liked, doing a guided meditation. Those kind of things are really, really important. We put up some myths here because people care about them all the time. We're not going to spend a lot of time on it, but you'll have these slides for reference on the website. So just to say, you know, morphine is a drug before you die. For some people, they are taking morphine before they die. I think the important thing is it wasn't the drug that caused them to have experience death. They were sick, they were on medication for pain or for shortness of breath, and it was necessary to treat their symptom. They still had that symptom up until the point that their natural death occurred. The side effects of pain medication are worse than the pain itself. Well, if you don't treat the nausea, you don't treat the constipation, they're horrible side effects, and yeah, that could be as terrible as the pain. So be proactive and move through and make sure you treat those things as well as the pain. And patients who have struggles with breathing should have an opioid prescribed in the dose right for them so that they can get relief of the shortness of breath. We don't ignore it, we treat it. Oxygen, some anti-anxiety medications, and opioids have a role as well. So, in a nutshell, what can we do to help patients who are palliative, those who are progressing on towards the end of their natural life? It's not a failure to not be able to take an illness away. It's a success to help people live well with it, and that's our role as healthcare providers, to improve quality of living. Focusing on the living well is an important aspect of talking to patients and families about how to move forward. Focusing on what we can do, not on what's not available. Always couch things in terms of that patient's goals of care. If the patient can talk to you, knowing what they want, what their priorities are really, really important. That's what we espouse in patient-centered care. And to reframe hope, as we both mentioned earlier, there's always something to hope for. Sometimes when we're afraid to talk about stuff, we're thinking because it's hopeless and we feel helpless. Patients will guide us. They will tell us what direction to go in, and we can then reframe things so that we have something to hope for. Pain relief, not throwing up, having my loved ones around me. And then all of this is to focus on what is the best quality of life for that person, because what's right for me, what's right for Susan, what's right for you guys may not be what's right for your person in front of you. So that's really, really important. And I think, you know, we've always said, and this is to help empower you guys, because knowledge is power. If you feel comfortable with knowing what palliative and end-of-life care is, then hopefully you'll feel empowered to talk to people about it, to understand what's important to them, to push your limits, to move into an area that you may not be 100% confident that you feel comfortable doing, but you know what? Practice makes perfect. You move through, and we're not looking for perfection. We're looking for an opportunity to engage people and talk. And to work with the team, to know that it's more than one person, it's all of us who work together. I think knowing that we have our own biases that we bring into our practice, we need to reflect on that and think about what this means to me as the person taking care of an individual who's living with a life-limiting condition, so that you go into it with an approach that you're open to the person and to meeting their needs. But you can't just hide what you feel under the rug. You need to acknowledge that within yourself so you can do this work on a daily basis and move through. And knowing that you yourself are as important as many of the drugs that are ordered here, and that it's you, the person, that supports the patient and their family. This is the resources we have here at Eastern Health. On the left-hand side is our Towards an Understanding of the Final Days booklet. It's available through the print shop, so if you don't have it, get it and have a look. It talks about symptoms, and it breaks it down under what you can do to provide comfort for an individual. And I particularly like the Caregiver's Guide, which is from the St. Lazarus Society and the Canadian Hospice Palliative Care Association. I give it out to community health nurses, and it helps with helping guide families with the care of individuals who are at end of life. Susan and I are both facilitators of the Learning Essential Approaches to Palliative and End-of-Life Care, which is the LEAP program. We've embraced that for many years now here at Eastern Health as our education that we provide. And this is just a breakdown of some of the topics that they include in that learning program. And that's it. As Meg said off the top, if you have any questions, please let her know, put a hand up, and she'll free up the mic so you can ask.
We stun people. If you're interested in the LEAP program, that's probably something to talk to your manager about, whether or not you can get that. There are facilitators all across the province who would probably be willing or interested in providing a LEAP program to you, or perhaps a modified LEAP. If you'd like a little bit more of this information in a interactive session with you and some of your peers and a facilitator.
If there aren't any questions, we really appreciate your time today. We're happy to be a resource. So if there's anything we can do to help guide you in practice, please let us know. And have a great afternoon. Thank you.